So today we are going to deal with the anemia second part. So first we will look at the causes of iron deficiency anemia. And it is due to deficiency of iron and either deficiency of iron in diet, non-exclusive, and in children or infants it can be due to non-exclusive breastfeeding and early introduction of complementary feeds, and the other is blood loss with menstruation, childbirth, peptic ulcer disease, polyps in GIT, colorectal carcinoma, hemorrhoids. Next is decreased absorption of iron from diet, decreased absorption. And then is increased requirement of iron as in pregnancy and lactation. Increased requirement. Like pregnancy and lactation. Then high risk group for developing iron deficiency anemia are, so in them we have to screen them frequently for iron deficiency anemia. They are women of childbearing age group, lactating mothers, pregnant women, and infants, children, adolescents. So these are the high risk groups for iron deficiency anemia. Next, symptoms and signs of anemia. So we can deal with the clinical features in anemia. So first, pale skin. So it can be in skin, tongue, lips, eyes, eyelids, conjunctiva, and fatigue, weakness, pica, unusual food cravings like rice, uncooked rice, ice, any other thing. And decreased appetite in children, impaired cognitive performance, reduction of physical activity. So decreased school performance, decrease in school performance or decreased memory performance, and other features like sore tongue, irritability, headache, frontal headache, shortness of breath, dyspnea on exertion, shortness of breath, orthostatic hypotension, and nail changes, brittle and concave nails, that's called koilonychia. So these are just some symptoms and signs. Next, about lab diagnosis. So in primary care we have to do basic investigations. They are HB, peripheral smear, and stool examination. And HB in CBC or blood routine we will get, peripheral smear, and stool examination for worms or any other stool occult blood. Then next, treatment. Treatment for mild anemia we can try with, first we have to advise on diet and treat the cause, identify and treat the cause. And in mild anemia we can give oral iron and folic acid. And the dose of oral iron is children 1 to 5 years 20 mg elemental iron plus 100 microgram folic acid per day, and children 6 to 11 years 40 mg, double of the 1 to 5 year, 40 mg elemental iron plus 200 microgram folic acid per day. Then adolescent and adults. Adolescents and adults, other males, 100 mg elemental iron plus 500 microgram of folic acid per day. And for pregnant women, same, 100 mg elemental iron plus 500 microgram of folic acid per day. And HB values should return to normal within 2 months of starting oral iron therapy. So minimum it takes 2 months for improving the HB values. But iron supplementation should continue for 6 to 12 months to replenish the body iron store. So we have to continue for 6 to 12 months to replenish the body iron stores. Parenteral iron is needed for persons who cannot tolerate oral iron. Severely anemic patients will require blood transfusion. Then in primary, so now we are dealing with only primary care. So indications for referral. So patients not responding to oral iron supplementation, all cases of moderate to severe anemia and associated comorbid conditions like cardiac diseases, renal diseases, chronic infections, anemia associated with pregnancy if HB less than 9 gram per percentage, other causes of anemia like hemolytic anemia, thalassemia, etc. So we by finding the cause we will investigate it, and also have to rule out other causes like hemolytic anemia and thalassemia. Now prevention. Nutritional supplementation, fortification of food with iron, promotion of exclusive breastfeeding for first 6 months of life, and iron folic acid supplementation. Then for prophylaxis, dose in prophylaxis. So in prophylaxis of iron and folic acid, for children 0 to 5 years, 20 mg elemental iron plus 100 microgram folic acid for 100 days in a year. And 6 to 10 years, 30 mg elemental iron plus 250 microgram folic acid for 100 days in a year. And adolescent 10 to 19 years, 100 mg elemental iron plus 500 microgram folic acid weekly. So that is 100 days in a year. So like 3 months in a year. This is in adolescents weekly we have to give prophylaxis. Then pregnant and lactating mothers 100 mg elemental iron plus 500 microgram folic acid daily for 100 days during pregnancy, followed by same dose in postpartum period, in pregnancy and in postpartum period. Also, we have to do regular deworming. Deworming with albendazole 200 mg, albendazole 200 mg for children less than 2 years and 400 mg for more than 2 years and adults. And single dose to be taken once every 6 months. Every 6 months. Then health education and environmental sanitation.